There you go. You should be able to share now.
Okay, there it is. Share. Okay. Can anyone see my screen now?
Yes, we're able to see your screen.
Okay, so I am going to start. My name is Stephen. I want to talk to you about this novel method to treat androgenic alopecia using microneedle radiofrequency with topical minoxidil. This is a pilot study that I did. This is my CV. I graduated from Erlangga University in Indonesia, and I did my postgraduate medical training, dermatology training, over at Boston University Medical Center in the United States of America. And below are the memberships, publications, and journal reviews that I did. Okay, first of all, androgenic alopecia, an extremely common condition. A lot of you most of you would have seen this. Some of you may experience this. This is an extremely common condition. What happens is that there is a miniaturization of the hair due to this androgenic hormone, and some people are just susceptible to this hormone, causing this condition called androgenic alopecia. And as I said before, very common, happen in about 70% of male and 40% in females. Righty, so in order to know how to treat this, we need to know, how does AGA occur? So on your right-hand side here, you can see these words anagen, there's the catagen, there's the telogen, and another anagen. So I'm just going to briefly go over this. The anagen is the growing phase. This is what determines the length of the hair. And then you would have the catagen, which is the stopping of the growth phase. And then you would have the telogen, the shedding phase. And then after that, you would have the anagen. So if you imagine it this way, so here, I'm just going to draw it right here. You would have the anagen going all the way from here to here. And then you have the catagen right here. And then you would have the telogen. So a lot of my patients tell me that, doctor, I used to have a lot of hair when I was a kid, and now I lost all my hair. Where has all my hair gone? So the expression that that a patient or humans losing their hair is actually incorrect, because humans are actually born with the same number of follicles from baby to adulthood. So what happens is that there is a shortening of the anagen phase. So instead of the anagen phase going all the way to here, you would have the anagen phase maybe here, and then you would have the catagen here. Or it can get really progressively worse, and then the catagen may start over here. And again, as I said before, the anagen is the determinant of the length of human hair. So when you have the catagen right here, instead of its normal position right here, then you would have what you call a miniaturized hair. And eventually this hair goes really short, and it kind of like goes really close or even hide under the scalp and cause baldness. Okay, so this is the normal hair compared to, this is the scalp with the normal hair compared to someone with an AGA. And you can see here on the left side here, you have this anagen hair going all the way from the superficial part of the scalp, the epidermis, all the way to the subcutaneous area. So this is a pretty long hair, healthy hair. And your right-hand side here, there is this scalp with androgenic alopecia. And you can see here that the hair follicles, they don't go as deep anymore. They only go all the way up to this lower dermis, and then they stop. So there is indeed a decrease in the size of anagen hair follicles, so-called miniaturization. There are also increase in the number of telogen hair follicles, because you would have more telogen now that the anagen is shortened. You would also have the fibrous tracts here. Oh, where's the fibrous tracts? Oh, right around here. Okay. So the question is, we know that the problem is the shortened anagen phase. The anagen is too short. How do we extend it? These are the current treatments that we have for AGA. So we have the Minoxidil, we have the finasteride, we have the dutasteride. There's also the cyproterone acetate, the spironolactone, the latanoprost, the ketoconazole shampoo. There's also the fancy LLLTs. They can come in form of a helmet or a comb, for instance. There's the PRP. There's the microneedles and fractional lasers, the erbium glass, erbium yak, and CO2s. And also there's the hair transplant that's been there for quite a while already. And yet we are still trying. So far, only 3 methods are FDA approved. Minoxidil is the classic treatment. I used to be trained, to talk to patients that Minoxidil is the only medication at the time that was FDA approved. There's the 2% and the 5%, but both of them offers relatively low efficacy. And during the first month, you can also have an increase of the shedding, which reduces compliance and patients no longer want to use it. What about LLT? So the LLT, we've looked into it for a while, but the thing is that with LLT, there's no variable wavelength. Some people recommend 630, some people recommend 655 and other wavelengths, and there are no consensus. Some methods are also limited to women only, for example, like cyproterone acetate or spironolactones. Obviously, you can't use those in men. And some methods are actually reserved for men only. For example, finasterides, although you can use it for postmenopausal women. Some methods are very difficult to perform. They're either too expensive and need extra preparation, for example, shaving hair, and you can have a longer downtime. This goes with hair transplants. So do we have any new ideas? This is my thought at looking at all these treatments. What about this fractional radiofrequency microneedling then? So in essence, fractional radiofrequency microneedling is a minimally invasive procedure. Okay, so it's not very invasive. It is a combination of microneedle and RF energy. What it does is that it delivers bipolar RF through insulated or non-insulated microneedles, you can pick, and it creates a controlled thermal zone at selected depth. I'm gonna talk a bit more about this later on. So Secret RF is an extremely useful dermatology tool. I've used it for a number of years now. It is a fractional radiofrequency microneedle, and what it does is that it utilizes bipolar radiofrequency. You can either choose the 10 pin, the 25 pin, or the 64 pins, and you can choose either insulated or semi-insulated. There is also the option to use the monopolar radiofrequency. There's the 1 pin, the 4 pin. There are also pins for vascular substitution and lipolysis cartridge. Excuse me. It can emit wattage to up to 70 watt on the 64 pin, 25 watt on the 25 pin, and 45 watts on the monopolar. So a pretty strong machine. So I'm going to talk more about the 25 pins. This is what I picked. Okay, first of all, that's what I picked because it is suitable size-wise. You can adjust intensity from 0 all the way to 100. You can adjust the pulse width, so you can set how long you want the machine to fire. And this is what I want to talk to you about. This is very important, is that there are variable choices of depth. You can go from 0.1 millimeter all the way to 3.5 millimeters. And you can choose how fast you want to fire the machine, or how fast it depends on how fast you want to go. Okay, so this is how it works. So the microneedle cartridge is placed on the skin surface. Remember, you have to place all this surface, this contact point, evenly on the skin. Otherwise, you would have an uneven treatment. And when you fire, when you press on the pedal, you would have these microneedles penetrating inside of the skin. And then again, the depth is, you choose the depth. And after that, the bipolar RF energy will be applied to all these target areas. And you would have this collagen regeneration and elastin production. And this is why this device is great for rejuvenation, facial laxity, pores, wrinkles, and acne scars. So this is the study. The aim is to observe the effect of secret RF, the microneedle RF, in combination with the classic treatment, 5% topical minoxidils. We enrolled about 10 males. We used AMLA as our topical anesthesia. We did it for about 45 minutes prior to procedure. And the interval was 4 weekly with minoxidil application right after. And then the patients were still instructed to apply 5% minoxidil twice daily. And we took images during every follow-up visit. Okay, so this is a patient that I did. This patient has just had his AMLA removed from his hair, so it's kind of like wet. And when the hair is wet, you can kind of see the affected areas more clearly here. So I'm just gonna draw it right here so that everyone can see. And so this is the affected area. You would want to take the picture from the back and from the front. Why can't I try? Oh, there it is. Okay, so here are the approximate affected areas. And then this is what we call the frontal hairline recession. And then you would want to kind of like look at the borders. Okay, so where do you fire the treatment? Where do you place your microneedle cartridges? Obviously, you would want to place them on all these affected areas, all the way here. So I like to do it from right to left or left to right. You can do it systemically or non-systemically at your own choosing. So as long as you cover all the spaces, you obviously want to cover all these areas. And besides this, you would want to do it on the border area. So the areas between the affected and the non-affected areas. Right here. And what I like to do is that I like to treat the seemingly unaffected area adjacent to the borders. So right along the outer borders right here. Same goes to the other image right here. Okay. So what about this frontal area? So in this frontal hairline recession, the affected areas are the bald parts, obviously. So you want to treat this area, the areas in front of the hairline. You would want to treat the hairline areas, which is the border. And you would want to treat the seemingly unaffected areas inside the hair. So these are the 3 areas that you want to treat. You don't have to do the whole scalp, but these are the most important areas you want to cover. Okay, so this is the video of me doing the treatment. Just gonna try to play. Oh, it plays. Okay, so this is how I like to do it. I like to go from right to left, and I do it slowly. I was talking to the patient while I was doing this, so it doesn't seem to be very painful. Right to left, and I like to go a little bit fast here, and I like to go at it, I like to cover areas multiple times because there may be some areas that I miss. And sometimes I also do it instead of from right to left, I also do it from back to front. So as long as you cover everything, the way you do it doesn't really matter. And on your right-hand side here, you might be able to see this mild redness. And obviously you would want to cover all these areas between the redness, but that's the kind of the rough idea of your endpoint. So you don't want to be too red, but you don't want it to be not red. So just this mild erythema would do. Okay. So how does it work, right? So obviously there are methods on how it works. So the secret RF, the microneedle RF, insert microneedles and release radio frequency energy. This causes vibration of the polar molecules and creates thermal energy, heat. And the heat causes inflammation. And this creates an increased blood flow and follicular vascularization. And all of these induces premature antigen entry. So you have a faster entry into antigen from, remember, if you have the antigen, the catagen, telogen, and another antigen, so you would have a faster entry to the new antigen. What about the wound? So the wound created by the needle actually stimulates stem cell populations and promotes differentiation of follicles. This is due, through the Wen, beta-catenin, and the LEF1 signaling pathway. And the wound itself, it creates a pathway. It creates a pathway from the minoxidil to actually get deeper into the scalp. So what about the choice of parameters? So on the left hand side here, you see this cross section of a hair. You have the infundibulum, you have the isthmus, you have the suprabulbar, and the bulb. And according to the studies that I've reviewed, is that the depth between the superficial part of the epidermis all the way to this, the end of the isthmus, where the erectrophyllae kind of inserts into the hair, where the bulge area is right around 1.5 to 1.6 millimeters. So what is the significance of this bulge area? This bulge area contains a lot of stem cells that we want to stimulate. So this is why we use the 1.5 millimeter depth. We use intensity about 30% and duration about 70 to 90 ms, depending on the pain level. So what happens if you use too much energy? This too much energy can actually disrupt the structural integrity of the follicular structure. You can destroy it. So instead of growing hair, you can actually make the patient bald. And this would likely be permanent. Okay, to see it microscopically, on the left-hand side here, image A, is that when you have a scalp and there is a microneedle being done on this scalp, particular scalp, the energy was delivered was so high, it causes a coagulation of the follicular epithelium and the perifollicular structure surrounding it. It destroys the whole hair follicles. If you can see it, there is fibrosis of these hair follicles, and this will cause permanent scarring. So very, very dangerous. But instead, on the B here, when you have just the right amount of energy, you would have this entrance, this hole is due to the microneedle, but you would still have this preservation of the hair follicles. And several days later, and in this study by Zheng et al., it's 4 days later, there is still preservation of the hair follicles. But you can start to see here, there is revitalization. There's some mixed cellular infiltration, neovascularization, and granulation tissue formation around the hair follicles. Again, with preserved follicular structural integrity. Okay, what about compared to other modalities, right? So CO2s can create pathway channels as well. It can create heat too. Sure, it does, but it can damage the existing hair. So unless you want to shave the patient's hair while treating it, I don't suggest CO2 lasers. You can approximate the depth of CO2 lasers, but you can't expect it to be extremely precise. But in secret RF, you can basically punch the numbers and you will get the same depth every time. And also in CO2 lasers, crust may occur, and this may be perceived by the patient as dandruffs. And what about regular microneedle? Regular microneedle works, but we find that it induces more pain, and often patient has a longer downtime due to edema. So these are the results. On the left side here is the patient, the before image. You can clearly see more of the scalp on the left side compared to the right. I mean, the AGA is still there, but the patient experienced a really significant increase in hair density, and he's very happy. So I'm not sure what's going on with the image on the left side here, but the visible area of the scalp has been reduced from all the way here to right around these areas only. So the patient is extremely happy about these results. Okay, what about this guy? So this guy experienced androgenic alopecia from all the way from the front all the way to the occipitoparietal area. This is not the right angle, but you can clearly see here on the occipitoparietal area or the vertex area as well is that there is an increase in hair density. This is a much better image that I took, is that clearly you can see an amazing increase of hair density. So instead of having all this thin hair from the front all the way to the back of the scalp, the androgenic alopecia is kind of isolated on this area as well, on the occipitoparietal areas. So patients very happy, amazing increase in hair density, very satisfied. What about the frontal hair? So in this patient, there is still some frontal hair recession. But if you look at the strands more carefully, there is an increase in hair density on the frontal hairline. This is why it's extremely important that we do on the affected area, on the borders, and also on the seemingly unaffected areas. What about adverse effects? Obviously, there can be some pain. Most patients do not feel much after the AMLA. And there are some redness on the scalp that will subside in a few days, usually 2 to 3 days. These are some of the questions that my patient usually asks me. How long does the procedure take? So the length of the procedure is usually depends on the affected area. The larger it is, obviously, the longer it will take. Is anesthesia absolutely necessary? I've done this with a couple of patients without anesthesia, and they feel like waiting for the anesthesia for about 45 minutes is not, takes too much of their time, and they would rather have it immediately. What about downtime? Well, essentially, no. There's really no downtime. You can go back to work the day after. But I would advise the patient to not use hair products or hair tonics or even hair wax or hair clays, pomades for about 5 days post-procedure. So is it dangerous? No, it's actually very safe as long as you know the right parameters. Again, the choice of parameters is extremely important, because if you are too excited about treating this patient, you may cause a coagulation of the follicular and perifollicular structures and cause permanent scarring. And you also have to be very cautious for those with primary cicatricial alopecia, for example, lichen planopilaris, or patients with autoimmune condition, because this can induce inflammation and worsening of their hair conditions. There will also be a possible contact dermatitis from minoxidil as well. All right, so what are the key points that we learned here? AGA is a lifelong condition. As the name implies, androgenic alopecia. The word genetic is there. So it is a lifelong condition. Many treatments, only 3 are FDA approved, relatively low efficacy. This secret RF, microneedle RF, can now be used as a novel way to treat AGA, but you need to have the correct parameter. And you need to wait between the treatments. So you choose 4 weeks because we feel like it gives the hair enough time to heal and to have this premature anagen entry. And we need to have patience, because not everyone will have great results after 1 treatment. Some of our patients have good results after 3 treatments. Some patients experience worsening after the 2nd treatments, and after that, improvement after the 4th session. So you need to be very patient here. Alrighty, thank you very much. And I will take some questions now.
Thank you so very much, Dr. Stefan, about the lecture. It was very informative. And
Okay,
I think that all of the doctors that present here will acquire some new knowledge. So there are some questions. I will
Okay.
read them for you. The first one is from Dr. Anthony, Indonesia.
Okay.
How and what is your consideration in choosing a depth needle for your cases? Which part you use shallow depth and which one you choose a deeper depth?
Okay. So the reason why I use the 1.5 millimeters is that because there are some studies that I've reviewed that shows that the isthmus, that the bulge area. So I'm going to, why don't I just share the screen again so I can show you better. Go back. Now, okay, so here this is where we are our target. Okay, so this is the bulge area that we're targeting. This is where a lot of the stem cells are. So, and the distance between the superficial, the epidermis, to this bulge area, to the insertion of the erector pili, is about 1.5 to 1.6 millimeters. But on the frontal area of the hair, where the patients usually have in patients with AGA, sometimes the patient already have a shortened anagen base. I would usually use a slightly shallower depth. I would usually use 1.2 to 1.5 because on the frontal area of the scalp here, it's a little bit more painful, and sometimes the anagen is a little bit, the hair is already a little bit shortened over here. So I would expect the bulge area to also be a little bit more shallow, but generally 1.2 to 1.5.
Okay, so another question.
Was that clear?
Was that clear, Dr. Anthony?
Hello, is Dr. Anthony there?
Okay, well, I hope it answered the question clearly. There are so many questions here. I will read you the next one. From Dr. Renata Costa, how many sessions?
How many sessions? So I usually use one cartridge, and this lasts usually about 6 to 7 treatments. So that's how many of the sessions that I do. And after the 6 or 7 sessions, after you use all these cartridge, I usually wait for about 3 to 4 months before I do it again. But if the question is whether you can do it continually, I don't see a reason why not. But this will obviously comes as a extra cost for the patient and extra effort as well.
Okay, so the next question is still from Dr. Renata Costa. What's the interval between sessions?
So as I said before, the interval is right about 4 months because we feel like it gives the skin enough time to heal. And then so we can do it again, because you don't want to do it too often, because if you want to do it too often, and especially with a parameter that is too strong, you can actually coagulate the follicular and the perifollicular structures, causing the permanent scarring. So you would want to give the time for the scalp to heal.
Okay, was that was the interval you said is 4 months or 4 weeks?
4 weeks. 4 weeks. Sorry.
Okay. So the interval was 4 weeks. Yeah. And the parameters was already mentioned.
Yeah, it was already discussed
by Gada Hana. And then from Suzanne, can you repeat the depths, please? It's also already been mentioned.
Yeah. And the MLA, I think we covered that. It's 45 minutes.
That's right. From Grace Lauren.
And you can use it for longer if you want to, but then patients could a lot of my patients are not very patient people. So 45 minutes is kind of like the ballpark that I do.
Okay, so from the next question is from Grace Lauren. How long does it take for significant result? Maybe let me clarify the question. Maybe it's asking about how many treatments does it take for significant results? And
so it varies between people. It varies between people, as you know, for AGA, sometimes you would have patients with really rapid progressive condition. Sometimes you would have patients with really mild AGA. Some patients don't experience any improvement during the first or second session, and they start improving by the fourth session. Some patients even experience worsening on the second session, but they experience improvement after the fifth session. So this is why patience is very important. Education is absolutely important, because patients can be very discouraged and they might want to stop treatment. This is a battle. This is a battle with the genetics, and it is a tough battle, and you need to keep doing this at least for at least 5 to 6 times before you actually, if you want actually to give up, at least 5 to 6 times.
Okay. The next question is from Dr. Ivan Makassar. Are your patients treatment naive, or have they shown inadequate response to conventional therapy? And the second question is, do you administer other regimens besides the micronidil RF and minoxidil?
Okay, so the treatments that the patients that are enrolled in these studies are they are not really treatment naive, but they have been free from treatment for at least for the past 6 months. So they have tried other treatments before, they gave up, and 6 months later, we do the procedure.
Okay.
What about the second one here?
The second one was, do you administer other regimens beside RF and minoxidil?
Not in this study. Not in this study, but then if you want to use other regimens, for example, like growth factors, obviously you can, but I'm not in this study.
Okay.
But I don't know the results. I imagine it can be very good, but in the purpose of this study, I did not. I use minoxidil because it's a classic treatment that that everybody should stop with.
Okay, great. There are so many questions, Dr. Stefan. Let me continue with the questions. How from Harish? How do we decide parameters?
So again, the method of deciding the parameter is again anatomy. The target is again the bulge area, is where the erector pili kind of like attaches to the hair, and this bulge area has a lot of stem cells there. So that's where you want to treat it. So the distance between this epidermis all the way to this bulge area is about 1.5 to 1.6 millimeters. But on the frontal scalp, where you usually see an already shortened hair, I usually reduce the depth of the needle to 1.2 because of this already small hair, and also increased pain in the frontal part of the scalp.
Okay, so the next question is from Rahik. I want to know the ideal parameters for this treatment. I think it is already answered.
Right.
Okay, so from Dr. Ruri D. Pamela. Any experience in using other topical agent with RF microneedle for AGA, and how do you compare?
So it's really hard to compare. So I've used it with other topical regimens as well, although those patients are not included in this study. I've used the growth factors, I've used the PRPs, but there's really no way to compare them because everyone progresses at a very different rate. But I think the best way to compare it would be to have a split scalp study. And obviously, it's very hard to have the patient have one part treated using one thing and another part treated using one thing, because they would want to have one hair, a little bit better, a little bit more dense towards the, compared to the other side. So yes, I've used it with variable results, but I cannot really compare between the minoxidil and the other topical agents.
Okay. The next question. Did you have the chance to, from Sinem Karacha? Did you have the chance to compare the results with patients using just minoxidil?
Yes. So all of the patients here that I've treated, again, 6 months prior, they were using other treatments. So one of the treatments they were using was minoxidil. So based on that experience, is that they feel that this treatment, again with minoxidil, just minoxidil, but combined with the secret RF, the microneedle RF, they feel that there is a much faster and a much more robust improvement. So this is from the patients themselves. But we did not do a split scalp study because the patient would want to have the whole head, the whole affected area treated, not just one part of the scalp. But based on their experience, yes, there is an improvement. So they've all used minoxidil before, and they feel like this time the minoxidil and the microneedle RF produces faster and much robust, more robust results.
Okay, thank you. So from Trang Mai, Vietnam, how many pass in one session?
Okay, so you want to cover the whole affected areas. It can be very hard for you to see if you skip some areas. So you might do the hair kind of like we go boom 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 boom, and then you would have the so-called skip areas. So this is how I do it, is that I like to go from left to right, and then systemically from left to right, from the front of scalp and all the way to the back of the scalp. And now I like to do it from right to left, just to kind of cover the skip areas. And I like to do it from back to front, so that I can cover the whole scalp.
I see. So basically, it's 3 passes then. Right?
Basically, the whole scalp, you need to make it red, mildly red, not extremely red, mildly red.
Okay, got it. From the next question is from Nila Pridadi. Hi, I'm Dr. Nila from Indonesia. What if the patient is allergic to minoxidil? Can you use growth factor?
I have used it only once. Obviously, you can. I haven't compared it, but you can.
Okay. From GP, what about alopecia areata?
Yes, so alopecia areata is an autoimmune condition. What happens is that in alopecia areata is basically your immune system is basically eating up the hair. I have not tried it in alopecia areata. I imagine the patient, this doctor is talking about possibly applying topical steroids on the scalp with alopecia areata. It's an interesting thought. You can use it, but again, you have to be very careful about the inflammation induced by the thermal energy. So there is always a risk of it worsening instead of it getting better.
Okay, thank you. The next question is from Poonam Naniwal. Is the result permanent?
So no, the result is not permanent. So again, this is a battle with the genetics. You would want the patient to be treated over and over again. I usually like to treat the patient with one cartridge and wait about 3 months before doing another set of treatments. The patient will progress with androgenic alopecia, will progress, and you have to battle the genetics to prevent this hair loss.
Okay. From Kaan Narwin, is there any older patients you treated, or did you only treat young patients?
Very interesting. So yes, I have treated, I'm not sure what you mean by old, but then I've treated patients who are 20 to 30 years old. I've treated patients who are about 40s. And I think the oldest that I've treated is about 60 years old. The reason is just that, that was the patient group that was visiting the clinic. And those are the patients who are willing to undergo the treatment. I cannot comment on whether the young patients actually will experience better results, because from this study that I did from 20 for about 60 years old, they all experience pretty much the same results, and they're pretty consistent all right across the board.
Okay, thank you. And from Ineke, Good evening, doctor. What is the endpoint of the treatment? How can you know whether you use the right energy or too high energy?
Okay, so the endpoint of the treatment again is mild erythema. You don't want edematous, very red scalp. So that's why I put the image on the presentation there. So mild erythema is good enough. So you don't want to have crust the day after. You don't want prolonged pain. You don't want edema. Just mild erythema is good. So always follow up with your patients right after. Do you experience any crusting? Do you experience any prolonged pain? So you need to talk this over to your patient, and then if the patient tell you that they are experiencing crusting or really bad edema, then you would want to reduce the settings after.
Okay, so again from Dr. Renata Costa, what's the delay time? The delay time used for the treatment?
Okay, so I assume this Dr. Renata has the machine, I think, because she knows the delay time. So what the delay time that I did was that I used was 180 millisecond, because I like to go, the pulse width that I used was 70 to 90 ms. So I like to go twice the amount of the delay time should be about twice the amount of the pulse width, so that it gives it doesn't damage gives a lot of damage. It doesn't give too much damage to the scalp.
Okay. From Dr. Anthony, can this method be useful for female pattern alopecia?
Absolutely. Yes, you can use it for female pattern alopecia, and I've used it to females. This is especially very useful for patients, for female patients, because it's compared to like CO2s, the CO2s can damage the existing hair. And female patients would not want to have their hair shaved prior to procedure, especially for 4-weekly procedures. So imagine that you have a 6 treatments, 4 weekly. So no female patients would want to have their hair shaved for about 24 weeks. Nobody. So absolutely, Sickle RF can be used, microneedle RF can be used for the scalp of females who experience female pattern alopecia. Absolutely.
Okay, thank you. And from Rika, hello, I'm Dr. Rika from Indonesia. Can the patient wash his hair at the same time, at the same day after treatment?
Yeah, no. So washing the hair, I don't recommend the patient to wash the hair, because I want all the minoxidil to be properly absorbed into the skin. But I do allow the patient to wash their hair the day after. And I recommend the patient not to use any hair products, including pomades, waxes, and any other products for about 5 days after the treatment.
Okay, from Chantal, did you use non-insulated or semi-insulated needle cartridge?
So what we used was the non-insulated needle cartridge, because we wanted to limit the damage on the right around the bulge area, and not necessarily to the others area. But if you use the semi-insulated ones, I don't imagine that would be much of a problem, because the wound that is caused, and also the heat causing it, can actually be beneficial to the hair, as long as you maintain the right parameter.
Okay, next one is from Henny G. Is the parameter also applicable for female pattern? It's already answered. And what about with minoxidil 2%?
Okay, so minoxidil 2% can be used, but I will also reiterate what my attending told me, is that minoxidil 2% is useless. So you already have low efficacy with minoxidil 5%. Why would you want to use the 2%? And besides, if you have too much hair, you can just cut it. Growing the hair is the difficult part. So why not? Why use the 2% if you have the 5%?
Thank you.
This is what she told me. I mean, no offense at all, but I think that makes a lot of sense to me, and I hope it does make a lot of sense to you.
Okay. From T, how soon after the session can the patient start using topical minoxidil?
So I did the topical minoxidil right after, and the patient can continue and doing it the day after, right the day after. But no pomades, no clays, no waxes, and no other products.
Okay. From Dr. Glenarda, Indonesia. Dear Dr. Stefan, for how long do we use finasteride for androgenic alopecia? And the second question is, what is the maintenance dose for finasteride?
Oh, finasteride. Okay. So I don't think we covered finasteride. What was the question again for finasteride?
For how long do we use finasteride for androgenic alopecia? And what is the maintenance dose for finasteride?
So finasteride is a 5-alpha aromatase inhibitor. It blocks testosterone from being the dihydrotestosterone, the active part of testosterone, the active form of testosterone. This is what causes the androgenic alopecia. The dose is right around 1 to 1.25 milligrams per day. And you can use it for a longer period of time. You need to be aware of the PSA, the process-specific antigen, because the finasteride suppresses this PSA level. You can use it for long in males. You need to also be aware of besides the PSA, also the possible side effects of the reduced libido and erectile dysfunction. But you can use it for longer, for as long as you are aware of the PSA levels and you communicate with the patients regarding the reduced libido and erectile dysfunction. And the maintenance dose is 1.25.
Okay, thank you, Dr. Stefan. The next question, there are 3 more questions.
Okay.
Please bear with it.
Everyone is very excited. I'm happy.
Yes. From Amaranila Lalita Drijono. Do you always combine with Minoxidil for these results? After achieving good result, did you maintain the result with the device as well?
Okay, that is a very good question. The reason why we use Minoxidil is that Minoxidil is the treatment that everybody has used. So we like to compare the experience with just the Minoxidil because that's what they've used, and compare it with when they have the Minoxidil along combined with the Secret RF. This is the reason why we use Minoxidil. I've used other topical agents, as I said before, the growth factors and the PRPs, and they also give good results. But I cannot compare the experiences because a lot of them have not used the growth factors prior. A lot of them have not used the PRP prior, so they can't really comment on is it better with the Secret RF or is it just the same. They can't really comment on that. But on Minoxidil, because they've all used it, it's a very common medication, so they can give their input. And regarding the maintenance, yes, you can maintain the results using the device. You can keep doing it for 4-weekly interval for many years. I don't imagine the reason why not. But a lot of patients are limited on the budget and also on the convenience. Not everyone can come for many years monthly. So what I like to do is that I like to use one cartridge and then finish up the cartridge and then redo it every 3 or 4 months after.
Okay, thank you. For the next question is Dr. Renata Costa. Do you apply Minoxidil immediately after the session with the needles? Yes, it's already been answered. Okay. Next one is from Iim Karima. Hi, I am Dr. Iim from Indonesia. What about the aftercare procedure? What should the patient not do after this treatment? It's already been answered as well. No pomade, no gels, no tonics, and do not wash the hair immediately the day on the treatment. Okay, and from Sinem Karacha. Have you tried lidocaine injections for anesthesia?
No, because the injection itself is very painful. So and actually hurts. The Secret RF hurts a lot less than the injections. And then when you have all this huge area of the scalp but that big, and then it's going to be hard to infiltrate all these areas. You would have a lot of different injection points, and that would be too painful for the patient. The other solution that you can do is to do a nerve block. You can do nerve blocks, obviously, but I find that the topical medication works, the topical lidocaine works, then I don't see a reason why we need to do the nerve blocks. But infiltrations is generally not a very advisable thing because the injections of the lidocaine hurts. And I don't recommend using lidocaine with adrenaline as well because it hurts, and second, it reduces the blood flow to the area.
Okay, thank you. So is there any, one more question, I think. From Trang Mai. Can you use secret combined with injection no needle budget HA solution? I think it's he's asking about another device.
Right. I don't have the device, so I don't have the budget HA solution. So I really cannot comment on that. But I think it's one of the devices that you kind of like have this really high pressure, shower to the kind of like the scalp, right? I'm not familiar with the device, so I really can't answer the question.
Okay. So from Dr. Renata, AMLA can make the scalp humid, and to use secret, the area should be dry. How do you deal with that? Okay, so the AMLA can make the scalp humid because it's a solution, it's a cream, right? I don't see a reason why secret has to be used in an area that's that's dry. We apply topical Minoxidil, which is a solution, right after the treatments. I find that right after removing the AMLA, the patient is a little bit more, slightly wet, and I can better see the scalp, the affected areas, the borders, and also the areas adjacent to the affected areas more clearly. So I don't see a reason why we can't use the secret on a humid scalp. Obviously, you don't want to use it to a really, really wet scalp, but because it's just gonna be messy, it's just gonna be water everywhere. But humid, I don't see a reason why not. Okay. A question for ILOODA. Do we still have time? Can we still continue? There are some more questions. It keeps coming. Everyone was very interested. I'm very happy. Okay, there's no answer from ILOODA. Then so I'll ask a question. Okay. From iPhone. iPhone. Yes. Is the Minoxidil spray or solution? It's a solution, but actually it's a solution. What I like to do is that I like to put it in a syringe without the needle, and I like to just drip it. Okay. That's how I do it. But you can use the spray if you want. So either way is fine, right? Either way is fine. As long as it's a solution, either way is fine. Okay. I believe that in the US they don't have the spray, but a lot of my patients back there, they used they would buy the bottle, and then they would have the dripper, and then they would just move the bottle into a spray, and they just use it from the bottle, from the spray. Okay. Last question. Further inquiries, you may ask ILOODA, and ILOODA will send the questions to Dr. Stefan. Yeah. The last question is: can we use combination of CO2 laser with secret for the scalp? Yeah. So you can per se, but then it would be impractical because the reason why we're using the secret is that we try to avoid the damage to the hair that may be caused by the CO2. So unless the patient has really short hair or willing to be shaved or bald, then there's really no reason for you to use the CO2.
in combination with the secret. This is the reason why we don't use the CO2, because it can damage the hair, cause crust, uncomfortable. My patients like to have treatments that are very low downtime, low maintenance, and low pain as well. So you can, but I don't see a reason why, because it's just impractical to do.
Okay, so that was the last question. Any further question?
Okay.
Please send it to ILOODA. And ILOODA, can you send us your email address, or so that the participant can email to you, so you can email the questions to Dr. Stefan and then answer later on.
Well, everyone can email me directly if they want. I'm just gonna put my.
Yes, that's a great idea. So you may also email to Dr. Stefan directly. Yeah.
There it is. You can all help increase my follower as well in Instagram.
It was a very interesting topic. It was a very nice presentation. Thank you very much, Dr. Stefan. I think everybody is very thankful as well, and they're very happy to receive the information. I hope that whatever Dr. Stefan has shared about his pilot study, it will be helpful on your daily practice, and it will be helpful ultimately for your patients. Again, thank you so very much.
Thank you very much. Okay, bye. Have a good day, everyone. Should we take pictures of what, Dr. Victor?
Yes, I've been taking pictures.
Okay, so you're way ahead of me. I hope you take my good side instead of my my sleepy face.
Okay, let me take another picture. Just one more time.
Okay.
1, 2, 3. Okay. Got it.
Everyone is opening their image.
Everyone is opening their. Yes, please do.
Yes, if everyone can open their camera, that would be amazing.
Okay, we'll take pictures together. I'll slide the pages when everyone is already opening their camera. Okay.
Okay. It's great meeting people from really far away. There's some people from Vietnam. Some people from the Middle East, Belgium, Europe, and many other places. Thank you.
Okay, so I'll take the picture now. 1, 2, 3. Another picture. Okay. 1, 2, 3. Okay.
Ready.
Okay, I guess that's all that opens their camera. Thank you very much.
Thank you so very much, all. I hope to share some more and hopefully in contact with you sometime in the future. Thank you so very much.
Okay. Bye-bye, all. Bye, Dr. Stefan.